Hello everyone, I'm just letting everyone join and start coming into the main room. It'll just be a couple of minutes, don't worry. And apologies that you have my name. I think just from the link I sent you, you are me. But don't worry, I know that you're not me. Sorry about that. Oh, and if you're wanting to change your name, oh, you already have, or you're ahead of me. Thank
Following
you.
Diane's lead there.
There we go, just doing all the wee technical bits there, changing names and things, but welcome everyone. It's great to see you all, and I'm sure there'll be even more tuning in afterwards on the recording. But I just want to welcome everyone to the Northern Areas BPSA Spring Area Conference on Sexual Health within Pharmacy. So it's quite a broad topic tonight, and we're going to be covering things that you maybe not thought about and maybe haven't considered before. But it's all great to prepare you for practice and to add to the course as well. So we've got a few speakers tonight. I'll let them one by one introduce themselves. We've got one speaker yet to join, don't worry, she's on her way. But we'll start with Diane.
Hi there, Fraser. Thanks for inviting me along today. And just to say, I'm Diane Crome, a sexual violence support worker from Rape Crisis Grampian.
Oh, thank you so much, Diane. And Stephanie.
Hi, can you hear me okay? Perfect. Hi everyone, my name is Stephanie Tyler and I'm one of the specialist HIV and sexual health pharmacists, currently working at Guy's and St Thomas's Hospital in London.
Oh, amazing. Thank you so much. I'm just going to double check on the other speaker. Not yet, but I'll keep looking at it. So I think we'll get a wee start tonight. So Diane, I think we were wanting to go first. Is that all right? So we can start with your presentation.
Yes, if that's all right. So Fraser, you kind of indicated that you wanted me to tell folks about Rape Crisis Grampian so that you can use it as a resource, and then to go on to sort of underline some of the things that are useful in terms of dealing with a disclosure of sexual violence for yourselves as healthcare supply workers. So if I can just try and bear with me to try and, oh, wait a minute. I don't think I ticked the appropriate bits there. Share my screen, death by PowerPoint, I know, but it's a good way to guide us. So as I'm talking, this is going to be a really kind of a bit of an information overload perhaps, but it is a way of kind of giving you a screenshot of what I felt was important. And obviously you can ask me any questions at the end if you like. This is not training per se, this is just kind of highlighting important points and things that you can go on to examine further yourselves. So Rape Crisis Grampian opening hours were Monday to Friday and 9 till 5. Inquiries and referrals can be made either by that phone number, which you can easily get on Google, and by emailing the referrals desk as well. So what we do is we support anyone over the age of 13. So we go from the age of 13 to whatever age of survivors who've experienced sexual violence, and that's at any point in their lives. We work with all genders, and we do not work with perpetrators of sexual violence or gender-based violence. We have a main support service, so that's what I do. My remit is to provide a listening service, providing emotional support, which is free to the survivors. It's confidential and it's non-judgmental, and it's staffed by a regular staff basis, and also we have volunteers who do a 10-week extensive training course to be able to provide this support. We have no session limits. We work in a really person-centered way, and there's check-ins to sort of make sure that the support is effective for the survivor. Unfortunately, we do have a waiting list. Our young person service is for 13 to 25s, and they have their own waiting list, are a specialised staff, and also do some group work. And in the groups, we have our main support service, so that's the 25-year-olds and over, works in an 8-week block. This childhood sexual abuse group, self-help group, is an ongoing rolling basis. Young persons group again is run in 8-weekly blocks, and the LGBTQ plus with four pillars, is planned and about to be ongoing. We also have an advocacy service, and this is anybody that a survivor who has already reported and is involved in the criminal justice system and requiring support with that. Survivor who's thinking about reporting, and that would be perhaps important for you if you're having a first disclosure scenario. Anybody who's already involved with the police having reported, or if they need support in court, we also provide that. We have a sexual violence prevention worker, and she goes into the schools providing a national programme to run it across Scotland in all the secondary schools and pupils, so from S1 to S5. The workshops are made age appropriate, and we cover topics such as consent, what is sexual violence, gender, sexualisation, and social media. And we can do personalised or specialised training for organisations such as how to respond to disclosures, why don't survivors report, what is sexual violence, what is gender-based violence, online sexual abuse, sexual harassment in the workplace, etc. And RCG can be contacted directly for queries or quotes for that. And they certainly do go into Aberdeen University and RGU to provide some training. Now, what helps with gender-based violence disclosures? And if I say stay calm, it sounds a wee bit patronising, I suppose. But the worst thing that a survivor can see is you looking like you're panicking. I asked a survivor the other day what helped in support, and she was able to tell me that she could tell me some of the scary stuff and that I wouldn't look shocked, and that she knew she could bear and share whatever else it was with me. So it's finding that way within yourself where you can calm and settle and stay attentive to the needs of the survivor. Do listen empathically and ask what they need. Do not assume that you know what they need. Empower the survivor, talk through their options rather than making decisions or taking away choices. And that does include whether or not they want to report to the police. be led by the survivor's pace and consider how you speak about gender-based violence in general and your attitudes, because you must always assume that you do not know if somebody else is going to be a survivor of gender-based violence. So it's kind of societal wide thing, really. Biggest help is believe and validate that person, and please don't victim blame or minimize. I'm going to talk about that a wee bit more in a minute. And do self-help, debrief. Taking on too much yourself or making promises you can't personally keep is unhelpful for you and for them. So after a disclosure, please do reach out, use some form of communication to share that load, because there is a responsibility that comes with it. So helpful attitudes, and it sounds really patronizing if I was to say, I believe you, but you have no idea how important that is, that they see and hear that you believe them and that they were not to blame for what happened. And I've got a wee video. I don't know if you guys have maybe seen it before, but I hope you're going to allow me to share this for a few moments. It's a wee bit of, it's taken a wee bit far, I suppose, but really sit with it and challenge yourself about your own attitudes around victim blaming, if you would.
Hey, did you hear?
No, what's up?
James is dead.
What? Oh my God, what happened?
Apparently somebody killed him at a party.
What party? Was he there alone?
At that big party off campus on Friday.
Oh man, wow. That sucks.
Yeah.
Was he drinking at the party?
Huh? I don't know. I guess some. It was a party after all.
Yeah, 'cause alcohol makes it harder to fight off a murderer, and he may have made some bad choices about who to talk to.
Well, everyone was probably drinking some.
Yeah. I mean, what was he wearing, though?
What?
Well, you know how he wears all those V-neck t-shirts?
Yeah, but
I'm just saying, if you don't want to get stabbed in the neck, consider wearing a turtleneck sweater or something.
I don't think that really...
Also, James was super friendly.
Yeah, poor James.
I mean, he was so outgoing.
Yeah, nice guy.
He talked to everyone.
Yeah.
So it's kind of no surprise that he eventually met a murderer.
What?
I'm just saying, if you don't want to get murdered, don't go around talking to strangers at parties and just expect it to be fine. Did he even blow the murder whistle that Student Life gave us?
No, I think it was in his coat. The murder happened so fast.
In his coat. Typical freshman move. I mean, 1 in 5 college students gets murdered. He should have been more careful. No one ever thinks it will happen to them.
I guess. His family must be devastated.
I know. They must be so ashamed that he let himself get murdered like that. It's got to be so embarrassing for them.
What? No, I meant...
So did they find out who did it? I mean, assuming it was a murder and not some assisted suicide thing. Hey, maybe James really wanted this to happen.
No, he definitely didn't. And it was definitely Robert. Some people walked in on the murder, but they didn't think it was any of their business.
Robert? Oh, he's such a nice guy. He's definitely not a murderer.
He is. He definitely did it.
Yeah, well, he just felt like ending James's life, and he did, but he's not like a murderer. Besides, James was such jailbait, you know?
Huh?
I mean, he just had that look that you can totally see wanting to commit a felony and murder him. It's perfectly normal. Poor Robert. Really, it's sad how many young people's lives are ruined just because they kill a few people in college.
Oh. Oh. Sorry, my screen sharing's gonna be a bit mad.
Oh, don't worry. I think we're all the same with the technology just now.
Let's pick that up again if I could. You guys hearing this okay, by the way, yeah? Let's just scroll down a wee bit. Cool, let's try that again. My apologies. Is that okay, Fraser? Can you see that again?
Yep, I can see that.
Yeah, okay. So, wee bit of a challenge there, asking you to sort of look at victim blaming, and it's so easy to just have picked up things from society or media that you're not even aware that you're carrying. So the next thing that I wanted to raise awareness is consent. And forgive me if I'm stating the obvious for you, but consent is yes, and consent is not a lack of no. And consent is an ongoing process and can be withdrawn at any time. Have you, Fraser, do you know if folk have seen the consent is like a cup of tea video?
I think definitely in Scotland, I think that's quite a common one, or maybe across the UK, the cup of tea one. But if you want to play that just now, even for the recording and everyone will see it, you know.
Or not. There we go.
If you're still struggling with consent, just imagine instead of initiating sex, you're... If you're still struggling with consent, just imagine...
No, maybe not. Okay, what I'll do is I'll pop it into the chat, and folk can have a wee look at that themselves later. My apologies. So I wanted to talk a wee bit more about empathic listening, and that is probably one of the biggest things that you can do for a survivor, is to oh yeah, we're catching up now. Here we go. Is to listen effectively to them. And by that, I mean concentrating fully on what is being said, how the speaker feels and looks, and reflecting or paraphrasing this in a non-judgmental way to show that you understand how they feel. And to be trauma aware, that if a survivor is in fight and flight or freeze and thaw mode, they may not look the way or sound the way that you expect them to. And empathic listening would sound like, you know, what phrases I might very often use. I hear that you feel upset, angry, whatever it is that they're telling you. It sounds like you were frozen, like you couldn't move, or you look really terrified, really giving back the presence of what you're seeing, feeling, and hearing from that survivor. And empathic listening is different from sympathy in as much that it uses their experience and not yours. It's not using the I know what that feels like. It's about the survivor's experience of that. Rape Crisis Grampian are here for any questions by rape professionals, and you can call RCG during their opening hours or email the manager, make referrals via the referrals help desk, or just the info desk for general questions. And very much we're there to support survivors, but also for others impacted by those disclosures. So we, for instance, have offered support before to police officers or first responders, family or friends of people who have experienced sexual violence. So we are there for that.
That was amazing. It's great to have those emails and resources and things that people can contact you with any questions. And of course, it's amazing to know that you are always there for the people that have experienced these kind of things.
Absolutely.
And it's good to know that we can even ask for advice from professionals and referrals and things like that. It's always helpful. And I think having helpful attitudes, as you said, is really important, and not saying, you know, just sympathy for the person, but actually hearing what they're saying.
What do they need? You know, it may not be that they want to report to the police. because that is in and of itself a tricky and traumatic process. So in the first instance, what do they need? Are they safe? What do they need to be heard and to be safe at this point in time? So always from their frame of reference.
Which is really important. It should always be person-centered whenever you're dealing with things like that. And I think that video about James was really powerful. I think it did send the message that
it does, yes. It can be really subtle. It's little things like you don't realise you've carried things that perhaps your parents or grandparents said to you about, oh, don't go out with red lipstick on. You know, you don't even realise that you're carrying that. So you really begin to think about it. And it's quite a challenge actually to have that level of self-awareness.
Definitely.
So thank you. But apologies for the video clip, but at least we got there. So thank you for inviting me along tonight. Did you want questions, Fraser, or is...
So if you are wanting to do questions just now, if you're wanting to jump off, that's okay. If not, that's all right as well. So if anybody has questions from the audience just now, that's all right. We can even give it a couple of minutes, and if not, I will let you be free, don't worry.
That's all right. What I'll do is I'll pop the contact details into the chat so everybody has that, and also the link to that consent video, so those who haven't seen it before can do so. Stephanie, hi there.
Hi, sorry to jump on. I just that was such an incredible talk. Thank you. Would you be in it would be fantastic for you to share that talk kind of with some of my colleagues that work in sexual health. I don't know if you'd be open, putting you on the spot a bit here, but to do talks in secondary care to kind of our HIV clinic and sexual health clinic. I think they would all love to hear from you.
For sure, you know, we're here on the basis of trying to help folk be alongside survivors. So anything that's going to help that is fair game as far as I'm concerned. But again, if you want to just drop a wee email to the manager, and I'll put it in the chat for you so you've got that, then, you know, absolutely. And you know, I'm very aware that what I did just now was a whistle-stop tour. It wasn't a training. It was just this is what you need to know. But then it opens your awareness of, okay, my CPD, I need to be looking at a trauma response. I need to be looking at, you know, my personal awarenesses. So it's a starting point for you.
Yeah, brilliant. Thank you.
Thank you.
I can definitely pass on any details and make sure that everyone knows that they can contact you as well.
Thank you.
So I don't think there's any further questions, but at the end I'll definitely make sure everyone knows. So you are free to go, but you can stay if you want to watch, but don't worry, I won't hold anyone back. That's lovely, and I think we were all we learned something there, or even just expanded what we know already. So for the next speaker, I probably first should introduce Yasmin, if you want to come on and even say hello.
Hi everyone, hi, my name is Yasmin. I work as a senior pharmacist at King's College Hospital in HIV and sexual health. I've just got a few slides to share as well, so I'll just share those now if that's okay. So I'll just go through these slides and then I can take questions at the end if anyone has any. Okay, so as I said, I'm a senior pharmacist working in HIV and sexual health at King's College Hospital. So firstly, I'm just going to give you a brief overview of some of the common sexual health conditions that we see, highlight some of the current challenges in sexual health care, and also signpost you to appropriate resources that you can use in your daily practice. And apologies if I'm duplicating anything that's been done before. So firstly, STIs and STDs. So what's the difference between an STI and an STT? Well, firstly, they're not the same thing. An STI is when a bacteria or a virus first gets into the body, whereas an STD is when the person starts to show signs and symptoms of that infection. So firstly, so my role, so I work at King's College Hospital, which is based in the Lambeth area. It has the highest rates of STIs in London, so almost 3,000 cases per every 100,000 people. And outside of London, this is followed by Brighton, Manchester, and then Liverpool. So my responsibilities, in my day-to-day role, I screen prescriptions for STI infections, antiretroviral therapy, and for genital infections. I also counsel patients who are starting antiretroviral medications, so just making sure they know what dose they're taking, looking out for any side effects. And then I also attend consultant-led ward rounds and MDT meetings. So we have these 3 times in the week. And then lastly, I also offer specialist advice. So sometimes we have patients that have swallowing difficulties and need to change formulation of their antiretroviral medication. So I help on that, and also managing any drug interactions as well. So STI, so they're a major public health concern at the moment. There are long-term complications if they're left undiagnosed and not treated. In 2019, there were around 467,000 new diagnoses. This was slightly lower in 2020 because we had the pandemic and some of the sexual health clinics were closed. So there was a decline in testing. Of the most commonly diagnosed STIs, chlamydia is the greatest, about 49%, followed closely, not closely, but followed by gonorrhea. So antimicrobial resistance. So this is an increasing concern in terms of sexual health infections. So we're seeing increasing resistance and decreasing susceptibility to antimicrobials. In 2018, the first line treatment for gonorrhea had to be changed from ceftriaxone and azithromycin to ceftriaxone by itself at a higher dose. And this was to try and help manage some of the resistance we were seeing. We've already had 3 cases in 2022 so far of resistant cases. So it is becoming an increasing problem. And we're also seeing an increase in multi-drug resistant Shigella in men who have sex with men. So I've just gone through the 4 main conditions that we mainly see. So the first one is gonorrhea. Infection is normally localized and affects the mucous membranes, so the urethra, cervix, rectum, and throat. It's normally transmitted through unprotected sex and sharing sex toys that have not been washed or covered. The key symptoms are thick green, yellow, or discharge, pain or burning sensation when urinating, and pain and discomfort in the rectum, and also bleeding between periods. And long-term complications if it's not managed correctly is pelvic inflammatory disease, ectopic pregnancy, and it can also lead to infertility. So the first line treatment, as I mentioned before, is ceftriaxone. But if there's like a culture has been taken and we know what it's susceptible to, then you can use ciprofloxacin. And the next one is chlamydia. So it has the highest prevalence in 15 to 24-year-olds. In the image on the right, there's a picture of a cervix that is affected by chlamydia, and also a picture of someone that has conjunctivitis. So this is normally transmitted through genital contact, or if infected semen or vaginal fluid comes into contact with the eye. The main symptoms are painful urination, unusual vaginal discharge, white, cloudy or watery discharge seen in men, and it can also cause conjunctivitis. Complications are also infertility, and it can cause inflammation of the testes in men. First line treatment for this is a course of doxycycline, and if that's contraindicated, then patients can have azithromycin instead. So syphilis. So we're currently seeing a rise in cases of syphilis in our area. It's predominant in men who have sex with men and are also HIV co-infected. Transmission is by direct contact with an infectious lesion, so through sex or sharing needles, and symptoms tend to develop around 2 to 3 weeks after the infection. So it's characterized by a small painless sore or ulcer on the penis, vagina, or around the anus. And in the pictures on the right, you can see that somebody has like an ulcer on their lip. And the picture furthest to the right is in advanced later stages of infection, where some patients get a widespread rash. It can also cause swollen glands in the neck, groin, or the armpits. And complications are also neurosyphilis and adverse outcomes in pregnancy. And we're seeing quite a few patients coming in with neurosyphilis now, which does need to be treated quite urgently. So first line treatment for this is normally benzathine penicillin as a single dose, or procaine penicillin can also be given as a 10-day course. For patients that have neurological involvement, we give them procaine penicillin plus steroids, and that helps to kind of offset a reaction that some patients might get when they first start the treatment. To check if treatment's been effective, we just have to check the titers and see if they've come down sufficiently. And if not, then patients can be retreated again. And then I come on to herpes. So this is normally caused by infection by HSV1 or HSV2. It does cause multiple painful blisters that leave open sores around the external genitalia, anus, thighs, or the bottom. And there's a picture of this on the right. So following primary infection, the virus becomes latent. So you can't actually clear herpes. It's just managed by giving courses of acyclovir to try and stop the virus from multiplying. So we normally give patients a dose of 400 milligrams 3 times a day. And this is higher in patients that are immunocompromised, so for example, HIV patients. And creams can be used to help manage the symptoms. So an example is like lidocaine, which can help with some of the pain. I'll just talk briefly about some of the women's health conditions. So you see quite a bit of vaginal thrush, and on the right, I have a picture of that there, characterized by a creamy white discharge, and it's mainly treated with antifungals. And then we also have bacterial vaginosis, which is caused by an imbalance of lactobacilli in the vagina. This normally causes a fishy smell and white, grey or watery discharge, and can be treated with a course of metronidazole. So now I'll come on to HIV. So HIV is a virus that damages the body's immune system, specifically the white blood cells, which are CD4 cells. And over time, it weakens the immune system and makes people more susceptible to infection. In advanced HIV, we tend to see patients with more opportunistic infections if their white cell count is quite low. So you might see them have TB or serious fungal or bacterial infections. ART needs to be started as soon as possible following diagnosis. This improves the long-term prognosis for these patients, so that's very important. And it's normally monitored by looking at their viral load and their CD4 cell count. So the aim of treatment is to reduce the viral load to less than 50 copies per mil. Some places are able to detect as low as less than 20. And I've mentioned U equals U here. There was a campaign, I think a few years ago, that was highlighting that if patients are undetectable, then it means they're unable to transmit the virus to any of their partners. So this is what we aim for patients to achieve. HIV management. So there's been a significant development in this area. We have more effective and better tolerated treatments out there. All treatment consists of a 3-drug regimen. So this is of 2 NRTIs plus either an integrase inhibitor or an NNRTI or a boosted protease inhibitor. So ideally, we want patients on 3 drugs just to keep their viral load as low as possible. Treatments can be tailored to the individual patient. So sometimes we have patients on other medicines that might interact. So we can change that and make sure that it's suitable for them. Adherence to treatment is very important. So as long as patients are taking their medication, they'll be virologically suppressed and can expect to have a near normal life expectancy. So I've just called this slide Watch This Space because in April, long-acting injectable ART will become available on the NHS in England. I think it might already be available in Scotland. And this has shown that cabotegravir and rilpivirine are effective as oral tea at suppressing viral load. I think they've said that this will benefit around 13,000 patients in the whole of the UK. So this is quite significant. Patients will need to take oral tablets first just to check that they can tolerate the medication. And then if they're fine on that, then they can have higher doses of the first injections and then 2 separate injections every 2 months going forward. There are some practical challenges. So at the moment, we have patients coming in twice a year, so every 6 months. But if they're on these medicines, they'll then need to be coming in about 6 times a year. So these are things that we'll need to manage, and there's also costs associated with doing the viral load each time as well. I'll just talk about PrEP. Some of you may have heard of PrEP, so that stands for pre-exposure prophylaxis. So it's a discreet and empowering way to protect yourself from HIV. Normally it's taken before and after sex or daily to cover unplanned condomless sexual activity. And I've just listed here which groups of patients it might be appropriate in. So HIV negative men and transgender women who have sex with men, HIV negative partners of a HIV positive person who's not virologically suppressed, so their viral load is probably greater than 20, and other HIV negative people who are at high risk, so if they come from a country of high prevalence, and commercial sex workers. And on the right, I just have a picture of the tablets there and what they look like. So stigma. So stigma refers to negative labels that are attached to individuals or groups, and it can lead to discrimination. There is still quite a lot of stigma around HIV, and we do hear this sometimes from our patients. And it's just important to try and combat this from kind of lots of different angles. So it can take many forms, including hostility, physical or verbal abuse, or avoidance and excluding that group of people from specific activities. So on the right, I've just got a few notes about how we can combat stigma. So it's important to talk openly about HIV, making sure that patients feel involved, using supportive language and language that's not stigmatized. So we don't really use the term AIDS anymore. We prefer to say advanced HIV. It's important to speak out to correct stereotypes, and education is key. So that's the message that we try to give to everyone that works within the sexual health service. So just finishing up, I'll just give some health promotion tips. So firstly, encourage STI testing. It's freely available, so everyone should be doing it. And use a condom every time you have sex to minimize the risk of transmission of HIV and other STIs. Have one regular partner or try to limit the number of partners that you have. Avoid sex when under the influence of drugs and alcohol, as this can affect our ability to make decisions. And where appropriate, some patients may be advised to get the HPV or hepatitis B vaccine. Here I've just listed some of the references and resources that I used in my presentation, and then just some sources that you can look for further information as well. And thank you for listening. Do you have any questions?
Well, thank you so much for that presentation. So I'll jump in before questions and just say that was amazing of you, and it's great to hear about the long-acting injectable ART. I hadn't heard of that. And it just shows that how advancing and how things are progressing within, I suppose, all pharmacy and all medicines are changing all the time. But it's amazing that there's new treatments and that it's not being forgotten about.
Absolutely, yeah. That's
so
true. Definitely, it will make such a big difference. And I think they did say around maybe 13,000 people will benefit within the UK. So it's definitely quite a significant change in the area as well.
So we do have a wee question from Jack. I don't know if you want me to read it or if you're able to see the chat.
No, if you could read it.
Yeah, no, of course, because I was thinking if you've got that open. So the first question is, what is the current guidance on testing for STDs and STIs?
So I think for patients that have multiple partners, we advise them to test every 3 months. And they can do that through the website links. They're quite clear, they kind of direct you as to where you need to go. I think if patients are with maybe just one partner, then they can test every 6 months, but it depends on the number of partners that you have. But I know there's specific guidance on each site regarding that.
That's amazing. I think it's good to know that, and we know to keep up to date with what the guidance is if we are going to be referring people or giving advice. But then always, when you do get asked a question, if you don't know, I always think it's easy to just check rather than telling people, because I wouldn't have known how often.
I think, yes, I know. I think I have seen about, 3 months if you have multiple partners, but I would need to, double check on the ones.
Right. So the next question is, what do you find rewarding about working in sexual health as a pharmacist?
I think it's just that it encompasses so many different things. So we have, if you want to say, a bit like a patient helpline where patients can call up if they're starting like a new maybe medicine they've bought over the counter and they just want to check if there's any interactions. So I think I really value having the interactions with patients. Some of them are quite concerned as well because they might be traveling and they want to check if they can get like further supply of their medicine. So we do get a lot of different questions about how to manage our patients. We've recently had a few on the wards that have TB as well. So we've had to look there at the interactions and giving them appropriate formulations because it hasn't been the standard regime that we can use for everyone. Some of them have liver dysfunction or other issues going on. So I kind of value tailoring the advice to each specific patient. That's very rewarding because you learn so much from it as well.
It's always important to, treat any patients, as individuals, and it's great including them in their care. And it's maybe something that I haven't even, thought. Obviously, you do the thing, but you don't often think about it. And it is really rewarding because you can see how it makes a difference in their life as well. So another question, have you felt any stigma or prejudice directed towards you as a pharmacist in sexual health?
I haven't actually, and it's been quite the opposite. I think people really appreciate and value it because they know that you would have kind of a lot of knowledge as to how to manage that group of patients and their medicines as well. So I've not personally experienced it. If anything, people have been quite, supportive and wanting to know more. Especially, we do get quite a lot of queries from pharmacists on the wards and how to manage a patient that's come in on the medication in their area. So that's been quite useful to kind of share learning as well.
It's good to know that as a specialty that it is something that people respect, and even the healthcare professionals, because I know what it can be like maybe in the hospitals if they're less kind, but that's great to know that you haven't had any problems with that. Also, Stephanie, if you wanted to jump in with any of these questions as well, working in the same area, don't worry.
Yeah, I think Yasmin's covered it really well. Apologies, I think I might repeat a few bits in the next few slides.
No, that's fine.
Another wee question, for a male pharmacist, how would you suggest overcoming any apparent awkwardness whilst appearing empathetic?
Sorry, can you say that again? Sorry.
Oh, sorry, I know. I think even me, I got a bit. Sorry. So for a male pharmacist, how would you suggest overcoming any apparent awkwardness whilst appearing? So I think while you're sort of speaking to any patients, how would you sort of overcome any awkwardness? And I think for everyone it might be a bit challenging. So when you're speaking to patients, how do you make sure that they understand you're empathetic to their situation, and particularly when it is dealing with women?
I think it's important to make them feel relaxed. So often if it's patients that have been newly diagnosed, I guess they can often feel the most anxious at the start, as in they're not kind of sure like how they're like it's the first time they've entered the service, for example. So we always try to just explore what their concerns are. I think that's very important. Just discuss that with them and outline what you can do for them, what the service offers. So we outline what the pharmacist role is, what our nurses' roles are, and the doctors. And then we also give them like appropriate links to online advice as well about things. But I think, yeah, it can be a challenge sometimes managing awkwardness, but I think it's important to try and make the patient feel as comfortable as possible. Yeah.
That's amazing. So I think that's all the questions for just now. I don't know if Stephanie, you'd like to start, and then at the end, if there's any further questions, we can sort of do it as a panel.
Sure, no worries. Thank you.
Okay, so I will just try and share my slides now. I don't know, it's just coming up with I cannot share whilst other participants are sharing. I don't know. Oh, here we go. Let me see. Okay, perfect. Can you see the slides there?
No, I can see them.
Yeah. Okay, perfect. Good evening, everyone. My name's Steph. I'm one of the specialist pharmacists working at Guy's and St Thomas's Hospital. And thank you first for the opportunity to speak to you all today. And it is my pleasure to give you a talk kind of introducing HIV, although it won't really be an introduction anymore, and a bit about antiretroviral treatment and from a kind of specialist pharmacist perspective. So apologies, I may repeat a few bits, but I'll kind of try and skim through them quite quickly if they are. So this slide shows a timeline of HIV and AIDS as a disease. So from where we started in the 1980s with people dying of AIDS-defining conditions to now HIV forming a stable, lifelong chronic condition if treated with optimal antiretroviral therapy. So the United Nations set a target that by 2020, 90% of people living with HIV knows their diagnosis, 90% are on antiretroviral treatment, and 90% are virologically suppressed. So that's having an undetectable viral load. And now we're moving also towards a fourth 90. So having 90% of people living with HIV having good health-related quality of life outcomes. And so we're really thinking about this in our clinics in terms of what does that look like for a patient. And I'm proud to say that London was actually one of the first cities to achieve this. Not only that, but with 95, 95, 95, which I think is absolutely fantastic. And alluding to the U equals U that Yasmin was speaking about earlier, so there's been a lot of research done about transmission. This was in the Partner 1 and Partner 2 studies where 0 discordant couples were followed up. So that's a person living with HIV who is on treatment and undetectable, having condomless sex with someone who does not have the virus. And the results combining these two studies show that there were over 100,000 condomless sex acts with 0 HIV transmission. And all of this research has showed and allowed the HIV community to come together and say with full confidence that a person living with HIV who has an undetectable viral load does not transmit the virus. And this is termed U equals U, which is such an important message to help reduce stigma, particularly with people experienced by living with HIV whose sexual partners may fear infection unnecessarily. And in 2018, so BIVA, which is our British HIV Association, which forms our guidelines for people living with HIV, made it quite clear that when talking about U equals U, it's not just a reduced risk by being undetectable, but actually we can say with certainty that it is 0 risk. And I think that's really powerful. And just to show how far antiretroviral therapy has come, so in the 1980s, the only drug available was called Zidovudin, which was first developed to be used as an anti-cancer drug. And this was used as monotherapy. And then when more nucleoside reverse transcriptase inhibitors became available, also referred to as NUCs, this became known as dual nuke therapy. And later on, when other classes of ART was developed, such as protease inhibitors and NNRTIs, this became the gold standard of care. So using 3 drug regimens known as highly active antiretroviral therapy, or HAART. And what's interesting now is that we've almost done a U-turn back and we're using 2 drug regimens for some patients, but this includes dolutegravir, which is an integrase inhibitor with a high genetic barrier to resistance, paired with another class, either lamivudine or rilpivirine. And the focus of antiretroviral therapy has also shifted. So in the 1980s, the aim of treatment was about keeping patients alive. And the primary outcome of trials at the time looked at survival rates, increases in CD4 counts, and reduction in the number of new opportunistic infections. There was poor understanding about HIV replication, and viral load testing only became available in 1995. The tablet burden was also extremely high. And not only that, but there were restrictions with food, side effects such as lipodystrophy, peripheral neuropathy, bone marrow suppression, and metabolic syndromes, just to name a few. And then the shift moved towards efficacy in the drug. So in terms of genetic barrier to resistance, safety outcomes, and suppressing the virus to an undetectable level. And now we are lucky. So we know the drugs work, and the focus is on finding a drug which is most tolerated and provides the best quality of life for the patient. This slide just shows the main antiretroviral therapy we use in practice today with all the different classes of action. And in blue, we have cabotegravir, a new integrase inhibitor, which paired with rilpivirine and NNRTI can be given intramuscularly. And in comparison to the vast number of tablets patients had to take before, we're now able to offer single tablet regimens. So just one pill once a day. And as you can see here, a total of around 10 SDRs, which are commonly used in practice today. Now, not to say that all patients can take them, depending on resistance, previous intolerances, and not forgetting NHS commissioning criteria, but it does give us so much more choice and aids in adherence, which is so important with antiretroviral therapy. So some of the discussions we're having now in our antiretroviral MDT meetings, where we discuss switch options for complex patients, is whether to go with these 2 drug regimens. And there's lots of factors we have to take into consideration, such as resistance, whether patients are co-infected with hepatitis B. But the rationale for using 2 drugs instead of the gold standard 3 is that it will mean getting away with 2 drugs will mean less long-term toxicities, risk of drug-drug interactions in our aging population, which has a lot of polypharmacy. So this slide just shows future treatments to come. So we have drugs in development with new novel sites of action, such as islatravir at a once weekly oral dosing, lenacapavir, fostemsavir, and the first monoclonal antibody abelizumab, which all of these in combination with other antiretroviral therapy can be used for multi-drug resistant HIV. We also have other new formulations such as rilpivirine patches, which has been tested in animal studies. Now, all these drugs may not be suitable or every patient eligible, but again, it just gives us so much more choice and allows us to bring the patient to the center of their care, making antiretroviral therapy more individualized. And antiretroviral therapy could be comparable to something like contraception, where there's multiple delivery device options available. And as you might have read in the news, NICE has just approved the long-acting injectables cabotegravir and rilpivirine, which in April will be available to prescribe in the NHS, which is going to be a 2-monthly IM injection. And this is a really exciting development, which can have the potential to change the lives of so many people living with HIV. We also have new drugs and formulations in trials for the use of PrEP. So PrEP is pre-exposure prophylaxis, like Yasmin spoke about. So generic Truvada is currently available via the NHS, which is emtricitabine and tenofovir disoproxil, either daily or event-based dosing. So new drugs in the pipeline for PrEP include islatravir, and because of its high potency and long half-life can allow for weekly oral dosing, yearly implants and vaginal rings, which could potentially be co-formulated with a contraceptive. And cabotegravir and lenacapavir, as well as being trialled for use as treatment, are also being trialled for use as PrEP. And looking to the future, so this is where some of the research is heading, is in HIV cure, or more appropriately referred to as HIV remission studies. And broadly neutralizing antibodies have been at the forefront of this research and could be used to potentially suppress the virus for an extended period of time without the need for regular antiretroviral therapy. One of the challenges with these is that patients have to come off antiretroviral therapy, which means very close monitoring of the patient and viral load to ensure that they don't transmit to their partner. So PrEP is really important here, and also that it's done in a very controlled clinical trial setting. The difficulty is that HIV persists during antiretroviral therapy due to the long-lived and proliferating latent infective CD4 cells. One strategy is known as shock and kill, and this is to eliminate the latency to activate virus production using these latency reversing agents, with the goal of triggering cell death through virus-induced cytolysis or immune-mediated clearance. And there have been major obstacles to this research, also because of HIV variability. So there's actually two different viruses, HIV-1 and HIV-2, and the virus mutates at breathtaking speed, and also due to its adaptation to the human immune responses. Something asked by our patients in clinic is, why is the COVID vaccine being developed so fast, but not a vaccine for HIV? Well, the COVID vaccine works by blocking symptomatic disease. It does not block infection. So for HIV, we have to block the infection much sooner, making the HIV vaccine development much more difficult. But what can we learn now from the development of COVID vaccines? Well, the importance of funding and collaboration between government, industry, scientists, and community. But we also don't want to make the same mistakes with the inequity of the COVID vaccine. And so how do we ensure that it reaches the people that really need it around the world? And what are the challenges we're facing with HIV? Well, we're dealing with an aging population, and what comes with that is multiple comorbidities and polypharmacy with risks of drug-drug interactions, and also the pressures of switching to generics. How do we ensure that there is inclusion and diversity in clinical trials so that they're representable of the people that we're actually using these drugs in? So for example, pregnant women, people of Black ethnicity, and those with low CD4 counts. And finally, probably the most important is how do we fight the stigma, which still to this day surrounds HIV, which some would argue is worse than the disease itself. So HIV stigma is negative attitudes and beliefs about people living with HIV. And a few examples of this is, so believing that only certain groups of people can get HIV, making moral judgments about people who take steps to prevent HIV transmission, feeling that people don't deserve to get HIV because of their choices. And this can affect the emotional well-being of people living with HIV and can lead to a negative self-image. People living with HIV may feel that they may be discriminated against if they reveal their status. And this can lead to feelings of despair, isolation, shame, and fear of disclosure. But what can you do to help fight the stigma? The language is crucial in challenging the stigma, and this is something we all can do. So most of us have had one of those days when everything's going fine, and then someone will just say one single word and that changes everything. And the language we use around HIV can be life-changing and break down these barriers. And we work really closely with community representatives, people living with HIV, and they have campaigned for years to change the way that we talk about HIV. And I think as clinicians, and you guys as future clinicians, we really need to implement this into our daily practice, not only with HIV, but other conditions too. So this was taken from the European HIV guidelines called EACS, and it was created for and written by people living with HIV. And some examples include, so the way we refer to someone with HIV. So rather than saying a HIV infected person or a HIV positive person or an AIDS patient, we would refer to those as people living with HIV. And also, rather than using terminology such as mother-to-child transmission, which assigns a certain blame, we would refer to this as vertical transmission. Other phrases such as an AIDS test. Obviously, there's no such thing as an AIDS test. You can test for HIV. And also referring or refraining from using the terminology such as unprotected sex, because having sex whilst using PrEP is a form of protection. Unprotected sex can be associated with promiscuous behaviour or that kind of term. So to use the language such as condomless sex. So where are we now going forward? The new target set by United Nations is to end the HIV epidemic by 2030. So that's 0 new transmissions, treatment for everyone, scaling up testing, and 0 discrimination. And what are the benefits of working in the field of HIV? I mean, this is a bit of my personal opinion, but I do believe HIV is one of the very few conditions which is treated solely with medication. So it can't be treated with lifestyle changes, surgical intervention, or physiotherapy, for example. So I feel the pharmacist has a really vital role here. In my experience working in the field of HIV is that the pharmacist is really valued within the multidisciplinary team. And I found medics to be very pro-pharmacy. And I think part of that is because we have such an important role in managing drug-drug interactions, resistance, counselling, adherence support, and polypharmacy. And as I touched on about a bit earlier in the presentation, so it's an exciting novel field of medicine which has lots of advancements with treatments, formulations, with treatment, PrEP, and HIV remission studies. So there's lots of opportunity for research as well. And just in case after this you decide you want to become a HIV pharmacist, I won't bore you too much with this, but essentially just kind of mapped out my career path to becoming a specialist HIV pharmacist. So graduated in the University of Bath and did my pre-registration year at Brighton, quite a large teaching hospital, and had the opportunity to work in HIV for a couple of weeks there. Got very anxious about securing a band 6 job, so applied for literally the first job that came out on NHS Jobs, which was in Guildford at the Royal Surrey County Hospital. So worked there as a rotational pharmacist through general rotations, dispensary, tech services, MI, and started the postgraduate clinical diploma. I then went on to move to London to take on a band 7 senior clinical pharmacist role with med safety, acute medicine, and 6 monthly rotations of also infectious diseases and HIV. And this was one of my favourite rotations. So then decided to go for a specialist HIV pharmacist role at Chelsea and Westminster Hospital, which kind of put me in good stead, it being kind of the largest clinic in Europe, looking after over 10,000 patients living with HIV. And I then pursued a highly specialist HIV pharmacist role at Guy's and St Thomas's, where I was fortunate enough to complete the independent prescribing course and currently do a weekly antiretroviral review clinic. And also what I think has been really beneficial is getting involved with national bodies. So for example, HIVPA is our HIV Pharmacy Association, where I'm the lead for the patient information leaflets. With BEVA, I do the education working group for practice MCQ questions. and BASH, which is the UK sexual health guidelines. I work on the syphilis guideline committee. And I think not only does this kind of help with your CV, but it helps with networking and kind of leads to lots of other opportunities. And recently have just been successful in obtaining an 8B pharmacist role for sexual health and PrEP implementation. So thank you for listening to me, and apologies for repeating some bits from before, but I hope that was informative and kind of challenged your perceptions as well. So thank you all for listening.
Thank you so much. So I was going to ask about your career path and why you chose it and what were the benefits, but you covered all them, which was amazing. So if there's any questions, but that was amazing to hear. And also all the new sort of treatments that are coming out, but also what the kind of future could be for patients. It's so exciting, and fingers crossed this is something that there could be a vaccine for in the future, although I have to say I didn't realise it was as different to COVID, because I think that's something I thought about, you know, with the COVID vaccine coming out so quickly, why can't we cure everything? But it's good to know that it's not as easy. But no, that was really interesting. So there's a wee question in the chat. I don't know if you can see that.
How did I find studying at Bath? Just had an interview. Oh, how exciting. Good luck. Yeah, I think I really enjoyed my time at Bath. I think something which is quite unique, which unfortunately I didn't go for, but in the 4th year they do placements abroad. So one of my friends worked in a hospital pharmacy in Australia for 6 months of her 4th year, which was absolutely incredible. And yeah, it's a lovely city. Not as maybe as busy as say like London or Brighton, but it's great, and the lecturers are fantastic and all kind of experts in their fields.
I have to say I'm glad I didn't have to do an interview to go to uni. I think that would absolutely stress me out, the thought of it. But well done for doing an interview, and well done for everyone else on the call who did interviews at the time when they went to uni and things like that. I was going to say fingers crossed I won't have to, but we're not going back in time. But no, that's definitely not unrelated. And if there's any other questions, well, we've got pharmacists here. What was it made you specialise in sexual health? Was it just enjoying it on the rotation, or?
I think I find it super interesting in terms of it's quite complicated when you really get into the resistance side of things, and just kind of, I mean, it sounds a bit cringing, but kind of supporting such a vulnerable cohort, I find that really rewarding. And I think quite often, well, like in other specialities, the patient won't tell the doctor certain things in the consultation, but then actually, you know, when you sit down with them and take the time to go through the antiretrovirals with them, they have, you know, all these other kind of concerns and worries, and you might not know all the answers, but just to kind of be there as a support and help kind of guide them through, you know, a new diagnosis is, yeah, incredibly rewarding.
And is there any advice that you would give to sort of MPharm students, or even year 13s that are going to be starting soon? Any advice that you would give about either on the MPharm or when you move into practice?
I guess taking as many opportunities as possible. So throughout my time at uni, what I thought the kind of pharmacist I was going to be at day one was very different. I thought I'd kind of work in industry, and then I thought I'd be a Boots pharmacist, and then by the end of it I was a hospital pharmacist. So getting experience in all of those fields during your degree is really helpful, because yeah, I mean, you can do your pre-reg in any of them, but I don't know how easy it is to kind of switch afterwards. I've kind of just stuck to the same thing.
That's definitely good. Yasmin, if you're wanting to jump in with any advice as well, that's absolutely fine.
Yeah, I just wanted to say, Stephanie, was a really great talk, and it was nice to see your career progression. I was just wondering if you like what it's been like working some of the national bodies that you were part of, and would you encourage people to get involved in that kind of thing as well?
Yeah, definitely. I think it's tricky in terms of work will not give you the time to perhaps do some of these meetings or any of the work. So if you're kind of prepared to do that, but at the same time, like they want us to be, you know, experts in the field. So we need to kind of get involved with these national bodies. I think it can be a bit daunting at the beginning when you're kind of on a meeting with, you know, like the big names in HIV or whatever, but actually like your input as a pharmacist is so relevant, and you kind of, you think that they know it all, but actually you know a lot of stuff as well. So yeah, I definitely recommend. I think HIVPA is much easier to get involved with.
Okay.
And then through HIVPA, they advertise a lot of stuff.
Okay.
They advertise all the Beaver and the BASH stuff to get involved with. So that's quite good.
Thank you.
Just double checking that there wasn't any more questions I hadn't seen. I think that's everything. And if no one else has any questions, of course, if you are happy to any questions from people in the future, I can pass on. I think that's everything. What I can do is I can pop a wee. Oh, lovely. So Philo has popped in the chat with different links for our events coming up, and I'll pop in the feedback form, and it's great to hear feedback that I can pass on to all the speakers. Just a wee bit just to say thank you, make it a wee bit personalised. Of course I'm gonna thank them. One wee sec. There we go, that's great to have the email address in the chat as well, Stephanie. So thank you everyone for coming along, and thank you so much to Stephanie and Yasmin for taking time out of your days as well, because obviously you are working, which I can't even imagine the challenge of it. I'm so glad that I'm still a student and working part-time. Working every day, oh no, not for me. Maybe one day. But thank you so much for coming along. And just to do a wee shout out for our next coming events. So we've got the Western Area Conference, which is the 18th of March. So that's this Friday, which is on alternative careers, which will be really exciting for people to see different roles within pharmacy. And then there's the Eastern Area Conference, which is on substance dependency. And that's the next day on this Saturday. So similar to this event, but on those topics. And finally, tomorrow's webinar on antimicrobial stewardship, which sort of fits in with tonight's, is from CPPE tomorrow night. And there's also contact details in the chat. Yeah, so the future events will be accessible via the recordings on our YouTube. So you'll be able to watch them and previous events, which is always handy, and we always get quite a lot of that extra views. But thank you everyone for coming along, and I hope you have a lovely night.
Thanks for organising, Fraser.
Yes, thanks for organising. Thank you.